Well, thanks so much, and always hard to follow Samin Sharma, and it's just an honor to be here for APVIC. Sorry, I can't be there in person. I actually am going to not speak a lot about thromboembolic disease, which is what the trial is in, because we have Dr. Lala, who's an expert on this and who's going to be specifically talking in that regard. I'm actually even more thrilled to have her speak because we grew up together, and I can't tell you how proud I am, and my wife too, that we're doing this together for you. So it's just really a pleasure to be here today. I'll speak more directly about cardiovascular manifestations of COVID-19, not just for cardiologists, but also for those that are taking care of these patients that sort of need to understand the basics and then when to potentially call cardiology. I do want to state that, with COVID-19, we view this as informational. Nobody, even now, and this is one of the most vexing things about this disease, has true knowledge on what's right and what's wrong with this disease. It's happened so fast and everything is changing that this is just expert recommendations, and we don't want anybody to sort of hang their hat on some of the advice that we might sort of provide through our experience. That having been said, experience like we generated in New York, but also unfortunately you're generating in India, is such that it'll inform and hopefully help future patients who have COVID-19. So to speak first, we're going to talk about the prevalence of cardiovascular disease, the impact of injury on outcomes, potential mechanisms, cases as well. I have 2 cases to show you that'll hopefully keep things fresh, and then indications for cardiac testing, workup, and then hopefully some time for some questions at the end. I'll start, at least from our standpoint. March 3rd, 2020 was basically when the second case of coronavirus came in the US, but these are our governor. And the issue really was that this is when community spread happened. Up until this point, it was thought that this would be something that was only going to be imported in. And I think, as we all know now, community spread is rampant throughout the world and has caused so many illnesses and deaths worldwide. Right after that happened, we had quarantines in New York, and I think the world sort of was looking at the US after having seen what happened in China and Italy, and this really marked the beginning of our experience. Interestingly, although COVID-19 was an infectious disease, our division of cardiology, just like Mount Sinai's, leapt into action, and we had a number of publications that came out, not only looking at what standards there would be for cardiac cath, but also what the cardiovascular considerations could be, and this talk draws upon much of that as well. We had publications across the board looking at this based upon the experience that we were seeing right before our very eyes. So let's talk a little bit about what's out there about cardiovascular disease and COVID-19. This first paper from the Lancet was one that sort of keyed everybody to the idea that those patients that were presenting more sick and those who were dying more frequently had actually existing cardiovascular disease. And so this is what led many of us to tell our patients in our outpatient clinics, you really need to be careful, and you really need to wear masks, socially distance, and do all the right things, because these patients were at higher risk. I can tell you in my own practice, it's remarkable. I've had patients who had spouses of patients who had no cardiovascular disease, who had horrible COVID-19 and perhaps even died. I've had other patients who I thought for sure if they caught COVID-19, they wouldn't make it, and they've survived. And like many other people that have a lot of patients, we've all experienced loss from our patients, either infected with COVID-19 or ancillary damage because of the pandemic. And I'll show you a slide about that at the end. Now, beyond that, though, there was a recognition that many patients actually had elevated troponins, and particularly high sensitivity troponin could be elevated, and the estimate is around 20% of patients, 20 to 30% of patients in unselected hospitalized patients. Now, interestingly, as you'd expect, the higher the level of troponin is, that's tied to non-survival and also degree of illness. And so many considerations were made that this is a type 2 myocardial infarction, but there are other reasons that this could happen as well. This is just a slide from JAMA Cardiology paper that I'm an associate editor for, and we published this paper, which we thought was very interesting, showing that mortality was significantly associated with cardiac injury detected by cardiac troponin. How could myocardial injury occur? Well, there's 2 things. I think actually there's multiple things, but the predominant mechanisms could be, number one, from the cytokine storm and the stress of that response, and then additionally from direct effects of this virus directly on the heart. And to what extent one versus the other are more predominant in individual patients and what predisposes in that way is not fully known at this point. But beyond these two sort of main hypothesized mechanisms, there are other things that can happen. You can have just the fact that there's increased myocardial demand in a patient with pre-existing coronary disease, for instance, that can be manifested. In addition, with this recognition of microthrombi and the fact that COVID is a prothrombotic state, there have been some who've supposed that this could predispose not only to plaque rupture and thrombosis, but also in situ thrombosis within the coronary arteries. I have heard some espouse that as a mechanism by which, for instance, anticoagulation and or systemic lytics could prevent, myocardial injury through that mechanism. I think that's unproven as of yet. We just don't know if that's actually the predominant mechanism. And so I would be a little bit hesitant, especially because some of these agents that we give can cause a lot of bleeding complications. So we want to be a little bit circumspect about that. The other reasons that you can get injury is electrolyte imbalances, causing a variety of arrhythmias, et cetera. And then finally, just adverse effects of therapies that we use to treat COVID. In fact, in many respects, especially in New York, but certainly Europe was similar in this way. The early treatment of COVID was just throwing a bunch of things at patients to try to see if they worked. And those things can have beneficial effects potentially. They can also have deleterious effects. And so we have to be cognizant of what can happen when we do that. So here's a case of a patient, kind of a classic COVID-ish type of case. Many of you have, I'm sure, seen this personally, but I just will go through it quickly. A patient who presented with risk factors, had some chest pressure actually, and didn't have a lot of hypoxemia. The troponin was elevated and the pro-BNP was elevated too. This is the x-ray. It was not that remarkable. The Chinese experience where they did a lot of CT scans has shown that if you were to do a CT scan on many of these patients, you might see subclinical things on the CT scan, subclinical ground glass, but that's not something that we've been doing a lot of here in the United States, partially because of the issues relating to contamination of the CT scanner, because most of our hospitals are mixed COVID, non-COVID. The Chinese did something very unique, and I think not something that either we could do in the US or in India, where they separated patients into COVID and non-COVID hospitals. In that vein, you could certainly do CT scanning, but for us where it was mixed, that was harder. Notably, here's the EKG showing some ST elevation. It's a little bit diffuse, but certainly suggestive of some degree of myocardial injury. Patient did go to the cardiac cath lab and had no obstructive disease seen in the cardiac cath lab. And of note, this occurs in, up to, 60%, 40 to 60% of patients, if you take them to the cath lab, that even have ST elevation that would qualify to go to the cath lab, don't actually have an acutely identifiable lesion. And this has been seen in 2 studies, one in the New England Journal and one elsewhere. The patient actually became acutely hypotensive, ultimately necessitated a balloon pump and was transferred to the CCU. Here's the echo. I think you can appreciate the hypertrophy. The function is a little bit sluggish. There's a small pericardial effusion as well. And this is not uncommon actually. And patient was sort of stabilized, treated with inotropes to butamine, ended up swabbing positive for COVID despite that x-ray that we showed, and ultimately the balloon pump was weaned, but this required acute CCU level of care to be able to take care of this patient, not only because of the balloon pump, but also the heart failure management. And ultimately at day 10, the EF had actually improved to 50%, and the patient did well. Now, beyond just injury, you can get myocarditis. And that was sort of the formulation in this case. The patient presented, relatively stably initially, and then decompensated, necessitating a balloon pump and inotropes. And so this phenomenon is increasingly recognized. It can be particularly severe. We initially were worried that this would happen very frequently. I don't think that that's the case, but it's something you need to think about. You need to do standard diagnostic evaluation. We did have restriction in terms of our TTEs, just because of fear of contamination and people getting exposed. But as of late, we've been doing these more regularly as we have a protocol in place now, how to clean, how to do this. And just remember that you can get both pericarditis and myocarditis together at the same time. In terms of myocarditis, remember, it still should be somewhat of a diagnosis of exclusion. And ACS, somebody who presents with chest pain, EKG changes, and positive biomarkers, you should consider ACS. And I can tell you that if you're so focused on COVID that all you see is COVID when a patient comes into the hospital, we see this routinely, you are going to miss legitimate acute coronary syndromes that perhaps don't have COVID or even have both, and could have been benefited by coming to the cath lab or treating them more aggressively. So just remember that in your mind. If you anchor only on COVID, you're going to miss other stuff. You can consider a diagnostic angiogram, but have a higher threshold to do it. Biopsies are really not feasible, and we did some MRIs, but again, this issue of contamination and diagnosis was a challenge. There's no real treatment algorithm for myocarditis. Remember that these were patients potentially targeting for anti-inflammatory therapies, but is that proven? We don't know yet, aside from what we know about dexamethasone in the recovery trial. And just remember that in general, steroids have an uncertain role for standard myocarditis. So this is maybe a COVID-specific thing for dexamethasone. Briefly, cardiogenic shock, we have seen this. It's a hallmark of severe disease, but it's usually distributed first, but we've done Swan-Ganz catheterizations to be able to sort this out. These are ways to follow these patients, and we do them at the bedside. We don't bring them anywhere else to avoid contamination. Typically, treat with vasoactive medications. We have used balloon pumps. We've minimized the use of Impella for the most part for this because it's in the cath lab and the maintenance of this is higher. We have used right ventricular Impella in some cases, rare cases, not frequent. And that's a really important thing to mention, is that you see on Twitter, social media, and elsewhere that people are posting cases of this, but remember, these are rare cases in terms of, you never see the denominator when you see things on social media. VA ECMO and VAV ECMO are considered in some patients. We have used it. This can be a very long, protracted case. I'm the CCU attending right now, and there are folks who've been on ECMO for over a month at this point. So it's just a challenge overall. Here's just another quick case, basically a patient who had a cardiomyopathy. This was what the x-ray presented initially, bilateral infiltrates. There was nothing really on the EKG, tested positive, and had a protracted course that, we were doing all the supportive care. The patient was treated initially on azithromycin, hydroxychloroquine. I'm not sure what's going on in India right now with regards to hydroxychloroquine, but I show this case because this can happen, and we've seen it. We saw this in the hospital. We saw not only this, but we saw Torsade and other cases too. And obviously now the data on hydroxychloroquine, I think, shows you that there's not really any benefit to doing it, so we don't do it anymore. This patient was weaned ultimately, but had that arrest, so that was a challenge. Finally, just really quickly, you can get decompensation of chronic cardiovascular disease in the setting of COVID-19. Remember, these people, many of the patients we see are vulnerable to start off with, and India is very similar. They have a lot of comorbidities, and these people don't do well if they get COVID. As I said before, there's some people who remarkably tolerate it fine, but many patients get worse. And it's hard to sometimes diagnose what's going on because the COVID x-ray can look like pulmonary edema, or the pulmonary edema x-ray can look like COVID. And so that's a hard thing to sort out, and you have to have a high suspicion for it. Word on arrhythmias, this was seen a lot in Wuhan. I'm suspicious that much of this might have been due to hydroxychloroquine, and this may go down. In fact, I would say anecdotally, we've seen less arrhythmias since we've gone away from that. But remember, if you're going to have patients or have patients on it, you need to be paying special attention to electrolytes, et cetera. We have protocols, we published them on how we do monitoring for this. This was back in the hydroxychloroquine era. We're not using it anymore, so this becomes less relevant, but it is important to be consistent with it. In the last couple slides, just a few things. When to order a transthoracic echo. We typically were doing them focused point of care, either in the ER, our fellows had them, or on the units. We found this to be much easier to clean and to deal with the PPE issues than a full formal TTE. And you can see of our first 1,200 patients with COVID, we only performed full TEEs on 74. I think that's changed now, but that's important to think about because of this issue of PPE. When to consult cardiology. I think in general, it never hurts to have a cardiologist on the case. We like to think we're good clinicians, and there are many specific scenarios of it. I can share these slides with you later, but basically any instability of the patient, any LV dysfunction, RV dysfunction, as Dr. Lala will talk about as well, any unstable arrhythmias, and then the ACS scenario in terms of teasing out when somebody should go to the cath lab or when people should do other care. In terms of cardiovascular medicines, the ACE and ARB issue, we know that basically people who are on it should probably continue on it. There are many society guidelines. At this point, I would say it's premature to do anything about whether you start it or stop it, but we generally continue it. Finally, from a cardiovascular perspective, as a cardiologist, remember, know your pulmonary and ICU medicine. Many people are intimidated by this fact, but remember, when you were a regular house officer in internal medicine, we were typically the best house officers. So back when we knew that, we were great at it, so we can learn it again. And it's actually exciting to learn this stuff again. Know about the range of MIs, know about the range of arrhythmias. Patients with cardiac manifestations are some of the sickest, and that's why we get called to help with these folks. I talked briefly about shock, and then remember, when you have transitions of care, it's important to split patients up and isolate them if possible, because otherwise you can run the risk of nosocomial transmission. We actually had very low rates of nosocomial transmission in our hospital, but that's because we had adequate PPE. And I'll leave you with a final thing, and don't forget the ancillary and collateral damage. This is, I think it's a direct cardiovascular manifestation of COVID, although it has nothing to do with COVID. This was a text message I got from a patient, 4:28 in the morning, their family members, just so-and-so dad passed away about an hour ago. Oh no, was it coronavirus? I was obviously very sad. They said it was coronavirus. This patient actually did not have COVID. And the reason that they died was because the healthcare system was overwhelmed treating with COVID, and it was likely just a regular coronary event. So my last slide is this one. New York, we suffered through a ton. After 9/11, we rebuilt, and this was the Freedom Tower that was built. After COVID, our infectious rate is way, way down, and we suffered a ton through it, but we will rebuild and we will be stronger. And I just want to show that as inspiration to you, because it's the worst thing for us is after what we've been through to see what is happening in other places, particularly India, Delhi, I know in particular. And we're just really, really rooting for you. We feel horrified by this whole thing, but I think keeping a positive outlook in the end will help everybody end up recovering, and we will see a brighter day. So with that, thank you so much for your time. I'm happy to take any questions.
Thank you so much, Ajay. I think we'll have Dr. Anulala speak, and then we can have the questions together, if it's okay with you.
Absolutely.
So our third speaker is Dr. Anulala, who works in Mount Sinai Hospital. And we are going to be learning from her about learning the hard way thrombotic complications in COVID-19. So as we all know that, initially we thought that most of the deaths are occurring because of pulmonary complications, because of infection or ARDS. But autopsies done in Italy and also in US and Europe actually gave us an idea that many deaths were occurring because of the thrombotic complications and VTE. And Dr. Anulala is an expert in this. She's an assistant professor at the Aichen Institute of Medicine at Mount Sinai and director of heart failure clinical trials. She's also the program director of AHFTC Fellowship, and she works with Dr. Samim Sharma in Mount Sinai Hospital. So she's one of the principal investigators, and also she published a very leading articles on this subject recently. So welcome to you. Welcome, Dr. Anulala.